I think if you're an interventional cardiologist and you don't like a bit of stress, then you're in the wrong job. And I quite like it. It's a buzz. So making patients better, that's a good thing. And there's nothing quite as immediate as a primary angioplasty. There's very few things where a patient comes in really sick, and on the end of your needle or the end of your knife, they're going to feel dramatically better. And that is what happens. So if you've got a blocked blood vessel, then you're lacking blood to the heart. If you're unlucky, your heart rhythm becomes unstable straight away, and you've had a cardiac arrest. So if you're lucky, it remains stable and you get to hospital with pain, sweaty, breathless, feeling like you're going to die. That is the feeling. And apparently it is the worst pain, except for childbirth, of course. You can see this end over here, this is looking not quite a nice white line, yes? And this is now looking dark. That suggests that there's a pool of fat sitting there, and I think it's a little eye of faith because I'm used to looking at these, but there's a lump here, a little volcano full of crud, basically. And when that volcano's cap breaks, that's when you get a heart attack.
The capability of saving lives is something that you appreciate, and the more you learn and the more you're capable of doing it, the more you enjoy it. Unlike other jobs where you have to wait maybe until you see the fruits of your labor, with our job you can see it almost instantly.
Wonderful. Okay, so we get into the blood vessels either from the leg or from the wrist, depending on personal preference of the operator more than anything else. And we pass the pipes up to the heart as quickly as we can, because here minutes is muscle, and so the faster we can do it, the better. The more heart muscle you lose, the more the chance that you're going to die as well. The longer you're leaving it, the more damage you're actually doing. Save the muscle, open the artery as fast as possible. And most patients, they're frightened out of their minds, and they lie very, very still during this. The time from the door of the hospital to having the balloon in the artery and opened up, for us is about just over 30 minutes. Okay, so that's pretty fast. They've gone from the front door of the hospital over, draped up, pipes in, made a decision what to do, get the wire in, blow the balloon up, about 30 minutes. So now here's a gentleman who's really got some quite significant coronary artery disease. Again, nice and fat at the top end, but we're getting the impression there's a bite taken out over here until it gets a bit fatter. And I'm really a bit worried about this area up here as well. Not so clear on this view, so let's take another view. Okay, now I think this really does show it to us. So perhaps it's fairly clear now that at this point here, it's really become very tight indeed. It's not the biggest of blood vessels even down there, but that spot there is something that I think will need some treatment. So we're going to go ahead and try and treat that. Okay, so the way we're going to do that is pass a wire through the narrowing. That's our railroad. And then over that railroad we'll get a balloon, and the balloon is going to try and squash the debris out of the way. Now, patients have asked me, what happens to all of that muck? Where does it go? Well, the good news is there's a lot of fatty space around the heart, and the blood vessels run just above the muscle. So we just push it out of the way. There's a lot of dead space, and most of the time we get away with that. Very occasionally, if you push too hard or you're unlucky, the chalk is tight and then suddenly gives way, you can produce quite a big tear there. So that's the risk of angioplasty. But most of the time you can push it out of the way, and then place a stent, which basically produces a very nice anatomical result.
You're always thinking twice about your decisions. You're always considering other options and alternatives rather than taking high-risk decisions without thinking about alternatives. So it's stressful, but it's a different type of stress. It's not chronic stress. It's kind of on-the-spot stress that goes away once the patient is better.
Mistakes are very rare, but arteries falling apart in your hands is not that uncommon. And so, I think although we enjoy our jobs, and it's very good to get the plumbing looking right, in the end there is a body stuck to that plumbing, and that body's important. And so, a bad day is if you lose a patient. Thankfully quite rare in cardiology these days. We're quite good at avoiding death in the cath lab, at least.
Does it come close to that sometimes?
Oh, it does. I think you can get, we've certainly had situations where the heart rate's really slowed down very dramatically, or the patients had that wiggly trace you see on ER with ventricular fibrillation. and that means zero blood pressure. That can happen even during just a straightforward diagnostic angiogram. But because we know it can happen, we're set up to treat it, and one shock with the defibrillator usually brings them back again.
So I did a night on call a few weeks ago where I came in to do my night shift at 8:30 p.m. and I was in the cath lab for 13 hours. We did 6 cases that night back to back of people having heart attacks. And that can be quite stressful, obviously, especially that any delay to the patient coming to the cath lab to have their angioplasty might mean loss in their cardiac muscle function, or even death. So stopping for a break sometimes is not an option.
In the old days, certainly when I was in training, it was about 10 days, 2 weeks in hospital, bit of clot-busting drug to thin your blood down, hope it opened the artery, and people really knew they'd had a heart attack. Whereas now, wham, in, sorted out, they're sitting up. Actually, they don't quite realise how serious a problem it was, because 50% of heart attacks are fatal. So they're in the lucky 50%, but they never knew it because they're feeling so well. And so they have to have it explained to them that you've had a near-fatal condition, stop the fags, take the tablets regularly, otherwise it'll happen again. It really is a big change in culture. Most cardiologists, they're type A personalities in the cath lab, and they're type A personalities out of the cath lab. So I know a good friend of mine, he was into jumping out of aeroplanes with parachutes, and there's other guys who do other sort of, racing car driving and things. So it's that personality type, we have to admit, that does the cath lab stuff. There's another brand of cardiologist that's less aggressive, less invasive, perhaps more caring, who isn't quite as aggressive as that. But if you're talking about the cath lab environment, then it's a type A personality. If you get a bit of a buzz about being a bit pressurised, then, I mean, that's what my wife says. If I go home and say, God, that was really busy, she says, I've got no sympathy, you like it. So I think stress, a modicum of stress makes you work that bit harder. A standard interventional cardiologist will be a plumber, and so there'll be some furring up in the arteries, we'll get rid of the furring. The plumbing can get a bit more interesting when it's very chalky, and rather than just balloon and stent, you might need to drill, you might need to laser inside it to get the balloon and stent in. And sometimes if it's completely blocked, then you might have a chronic occlusion, total blockage, and then of course the wire is quite difficult to get through in the first place. So they're more interesting plumbing tasks. I also do a fair amount of structural heart disease work, in other words, where it's not the blood vessels that's the problem, the valves, or even holes in the heart. So I close small holes, little flaps, bigger holes if we find them in adults. So I'm not a paediatric cardiologist, don't do kids. And the aortic valve, whereas a standard operation has been cut, replace the valve, surgeon does it. In the high-risk cases at the moment, where surgery might be too high risk, patient might not make it, we're offering a minimally invasive approach where you have a cut which is only 2 or 3, 2 centimeters max in the leg to get a pipe in which carries the valve. So much like the stent in the blood vessel, this is now a squashed down valve inside a stent, and you can blow that up and put it into the aortic valve position. Seems to be working quite well. We can pick up a hole which may be causing a strain on the heart. Now those sort of holes we can close with an umbrella device these days, which goes up from the leg. The other group of people that I have a look at are those who have a PFO, a patent foramen ovale. Now that's not a hole, it's a flap. And you need that flap to open to bypass the lungs in the womb because they're full of fluid. They're not doing anything. That bypass valve closes as soon as you take your first breath, and in 3/4 of people it sticks, whereas in 1/4 it doesn't stick. Doesn't mean I'm going to close holes in 1/4 of the whole population. You have to index yourself as a troublemaker, and you're a troublemaker if you go deep sea diving and you get scuba diving and you get decompression illness. We look for holes in the heart. And if you have a stroke at a young age, now until I got into the game I thought stroke 70, 80, absolutely, but actually the stroke unit's full of 40, 50-year-olds who quite out of the blue have had a stroke, and in those sort of patients we do look hard for strange causes, and one of those strange causes is this flap, the PFO, and closing it, there's some evidence at least it reduces the risk. Yeah, it makes it easier. So we've got Try that. Okay, fine. Good. So let's take some nitrates here. Yeah. Just do a little test, make sure it's all right. That's fine. Okay, good. So we'll just... how are you feeling there, madam? You all right? Good. To fix that right up. We want a nice stable situation before we start. Actually, in a primary angioplasty situation, this is very common, and the heart rate can be doing all sorts of strange things, and so we're very used to dealing with it. A little bit of medication, and we should be okay. So
just flush it well, please.
Relax your legs as well, okay?
leg up, and is there someone else? Do I require? Must be a faster button to actually press for that if we're going to use it a lot. Yeah, that's fine. Okay.
You see it, but there was clot all down the right coronary artery.
Well, we need to be able to see it.
Well, I IVISed it, so there's IVIS images here as well.
I think this is the follow-up because you've got very little. So go to.
This is the follow-up. You're right. Yeah.
So just go to the proper one. Oh, we'll give you an IVIS as well.
So
Okay.
I've got IVIS here. So basically.
So just go to the right coronary artery because I've told them what.
MI. So it comes in. I was on with Nigel. I have a look. It just doesn't
No,
look
that's not a good
right.
case. That's not a good case because it's.
You can't really see. But the IVIS was good. I wired it and exported, and lots of clots came out. And then